So from a definitional standpoint, I think overarching wise, we need to think of worsening heart failure as a distinct phase of the heart failure disease and really a progression of the disease. But to really think of it concretely, I think of really four key elements go into the definition of worsening heart failure. First, you need to have worsening signs and symptoms. Two, it needs to be in a patient with chronic established heart failure. So not brand new heart failure, but someone with chronic established heart failure. They need to have those worsening signs symptoms despite some stable background therapy. So they need to be breaking through some level of background therapy. And then fourth is that their worsening signs and symptoms require an urgent escalation of therapy. And that's usually defined by, unfortunately, either going to the hospital for worsening heart failure, receiving outpatient IV diuretics, or even potentially receiving augmentation of oral diuretic therapy. So those four key elements really go into the definition of a worsening heart failure event. Now, importantly, within that definition, that a worsening heart failure event was traditionally thought of as synonymous with a heart failure hospitalization. But now we need to recognize that worsening heart failure is totally distinct from the location of care. It can happen both inpatient or outpatient. And to think of instead things like heart failure hospitalization as morely a treatment strategy for worsening heart failure, but not synonymous with worsening heart failure itself. You can also treat worsening heart failure by outpatient augmentation of oral diuretics, for example, or outpatient IV diuretic therapy. So that's really kind of the nuts and bolts of how we think about worsening heart failure. And then I think your second question was, well, is this being adopted within clinical trial design? And I think the answer is a resounding yes. Both from an eligibility criteria, we are now seeing more and more clinical trials that are enrolling patients not just in the outpatient setting or not just in the hospitalized setting, but across the spectrum of different care settings. And even the patients populations that are wanting to get worsening heart failure patients, they're not just including hospitalized worsening heart failure patients, but they're looking at outpatient IV diuretic users, for example. So again, we have been successful in getting some clinical trials to be more flexible in their designs and have an all-encompassing inclusion criteria and including worsening heart failure in their eligibility, not just hospitalization for heart failure. But then on the other end of the trial design spectrum, we're talking about the study endpoints. And this is also where you're seeing an increasing use of worsening heart failure. Traditional primary endpoint in heart failure trials has often been cardiovascular mortality or heart failure hospitalization, that composite. But now we're seeing more and more a composite of cardiovascular mortality or worsening heart failure. And that worsening heart failure component includes hospitalization, or outpatient IV diuretic. So again, including that outpatient IV diuretic patient as an endpoint in our clinical trials is becoming increasingly seen. Yeah, no, unfortunately, I think there still is an overwhelming lack of therapeutic urgency with the whole treatment of heart failure. And when you really just look at the objective data, heart failure has a prognosis comparable to a cancer. That is the objective data in terms of the risk of death, the risk of morbidity. Yet the culture of care surrounding cancer and heart failure therapy are drastically different. For cancer, there is this therapeutic urgency. There is a sense that we need to get therapy on quickly and that we need to, even have a tolerability for side effects and really just to have those chemotherapies, for example, be administered. But in contrast, for our patients with heart failure, despite on average our therapies being much more efficacious than the average chemotherapy in terms that our standard therapies reduce all-cause mortality and they improve quality of life. That's a very high bar. And then also our therapies are on average much more well tolerated than cancer chemotherapies in terms of clinical trials showing the rates of drug discontinuation are very comparable to placebo. And total serious adverse events are usually numerically fewer with GDMT versus placebo. And then also our therapies compared to cancer chemotherapies are on average much less inexpensive. The newly approved cancer drugs in 2020, 2021 had a cost of around $280,000 per year, Whereas you look in heart failure space, we have some branded therapies, but they certainly have a retail price much, much less than the average cancer chemotherapy. But then also we even have generic therapies, things like an ACE inhibitor, beta blocker, and MRA, which are all mortality-reducing drugs. Median out-of-pocket cost for a patient for a year would be $160 median for 3 life-saving, all-cause mortality-reducing drugs. Yet you look in the real-world evidence, we have less than 1 out of 3 eligible patients with HFrEF getting even triple therapy with 3 generic medications. Then you look at quad therapy, which is really the standard of care. That includes an SGLT2 inhibitor and hopefully an ARNI as well. We have less than 1 out of 10 of our eligible patients receiving that standard of care therapy. I mean, just imagine if you had a cancer population where less than 10% of them were getting appropriate therapy. That would never be tolerated. The culture of the United States healthcare system would never tolerate a cancer patient population less than 1 out of 10 getting appropriate therapy. Yet that is exactly what happens in heart failure. And every day, unfortunately, in this country, there are people passing away or having hospitalizations. And this is happening because they are not receiving therapies definitively proven to prevent these events. So we could make such a big difference if we had implementation of these proven therapies for our heart failure patients. And unfortunately, we haven't really been able to move the needle in the last few years on this. Yeah, it's a great question. And this is hotly debated in academic circles is what should we call heart failure in our specialty in general? Should we call it heart function? Some people even want to call it like heart success. As you said, is failure too scary for patients? I mean, my personal view on this is that I think when I look at the real world evidence for how we are using our evidence-based therapies, when I see the tempo and the urgency or the lack thereof with which we're using our therapies, I worry that if we changed it from the name of heart failure to something like heart function or even another term, I worry the unintended consequence would be that we even make things less urgent, less important. And I think it's almost somewhat disingenuous to try to sugarcoat what a diagnosis of heart failure really means. I think there's already plenty of data showing that patients with heart failure overestimate their survival. They are already not, on average, well informed of prognostically what it means to have heart failure. There is already not a sense of urgency among the patients and the clinicians for how to handle heart failure. So I worry that if we try to make the name less scary, so to speak, we could potentially, again, have the unintended consequence of making this lack of urgency problem even worse. And of course, we don't want to scare patients with the name heart failure, but we also want to be transparent about what we are dealing with here. And I think we owe it to our patients to be open and honest about just what the numbers look like with heart failure. But at the same time, to recognize we need to take it seriously, but at the same time, recognize that we should have a lot of hope because the good news is that we have multiple evidence-based therapies substantially proven to decrease the risk of death and morbidity, improve quality of life for these patients. So again, there's that urgency with what the diagnosis means, but it needs to be paired with a message of hope because we have very effective tools in our toolkit.